I'd like to now invite Professor Mahipal Sachdev sir for his talk on tough nut to crack, managing hard cataracts. And as we said earlier, sir has been one of the pioneers of phacoemulsification in our country and been the one of the best leaders that India has, especially during tough COVID times. He was the president of the AIOS. He's the chairman and managing director of the Center for Sight Group of Eye Hospitals. We welcome you, sir, to this IC.
Thank you very much, Dr. Anaga, for having me in the course. I'll be talking about phaco in hard cataract. As we all know that various grades of cataracts exist, and from a particular perspective, I would say both a soft cataract and a hard cataract are tough nuts to crack. But in this particular talk, I'll be just concentrating on phaco in hard cataract. So when you are looking at a hard cataract, why is it that a hard cataract is a challenge? I'll go over the various reasons as to why it is a challenge. So this is typically the look that you have on the slit lamp when you are examining a patient for hard cataract. Various people have reported various percentages of complications when you are handling a hard cataract. But one of the important studies has been by the Swedish capsule rupture group, where it has been shown white and brunescent / hard cataracts are always associated with an increased risk of capsular complications. So this is the baseline as to why we are discussing this particular event, this particular cataract management today. Now, when you are doing a hard cataract, it is important for you to be prepared. It should not be that you are on the table and you are totally ill prepared. That is there. In today's world, checking pupillary dilatation and specifically being prepared for IFIS, because the hard cataract is usually seen in older patients, has been sitting there for a long time, and nephrologists and urologists are now using tamsulosin left, right and center. It is also being used in women. So let's not value the kind of history taking that is there for looking at the pupillary dilatation. Once a patient comes to me for the final examination, the pupils are not dilated, old elderly gentleman, the first question I ask him, are you on any medicines for prostate? And more often than not, that's the answer that comes. The second thing that you have to do is that because these are older patients and a lot of them have diabetes along with it, you need to have a look at the corneal endothelium. Obviously, it's better to do a specular microscopy, but in case you do not have access to a specular microscopy, even a specular reflection on a good slit lamp will tell you. Again, a lot of complications in hard cataract because of increased maneuvering would also compromise an already compromised zonular integrity. So you need to look at the zonular integrity that is there. Please grade your cataract as regards what grade of cataract it is and what kind of energy, etc. you have to take. Often, posterior segment problems like high myope, etc. That could be a reason for the cataract to be there for a long time. A lot of patients, they know that they had an operated RD. Patient hasn't recovered good vision, has almost given up that eye, comes back to you after 10-15 years, doesn't give you the history of RD. So that is one of the things that is there, that you need to do a posterior segment evaluation. In case the posterior segment is not visualized, please do an ultrasound B scan. That is something that is required. Now, what are the intraoperative challenges that you have in a hard cataract? When you are looking at a hard cataract, first thing is that the visibility is often compromised, and that is because you don't get a good red reflex in these particular cases, and the milky fluid. So if you have an intumescent cataract along with a hard cataract, that makes the situation still worse. So the milky fluid would obscure your vision as regards the red reflex. Then going on to the capsular excess, I think in hard cataract, I always use trypan blue, because one is the visualization is bad, and the second is that often there is fibrosis in the capsule in these cases. So you need to be very careful for being able to do. If you get a bad capsular excess right in the beginning, if there is an extension in a hard cataract, I think you are in for trouble, because you can't levitate the nucleus forwards and do a phaco, because that is going to be bad for the corneal endothelium. Then the next thing is evaluate the AC depth, because these cataracts have been sitting there for a long time. Because the cataracts have been sitting there for a long time, the space for manipulation is less. Corticocapsular adhesion, so don't do a forceful hydrodissection, or do not forcefully try to rotate, because that can cause zonular dehiscence. But the main thing I would say is the nuclear changes, and in the nuclear changes, the backbone or the spine of the nucleus is what is required to be broken, because you have these interdigitating fibers which remain right at the end, and that is something which will not allow the nucleus to separate. And if you do not make it into a hemisection and then make it into smaller sections, the whole thing will try to come and you get posterior capsular rents in these particular cases. So for me, the most important golden rule is split the nucleus into halves and then make it into smaller sections. That will be something good. Now, one important thing for people who are beginners is that if you look at the anatomy of the nucleus, as you can see, is the thickest in the center, which is there. And it is more easy to do a phacoemulsification in the periphery. So people tend to go towards the periphery and do a phacoemulsification. That is going to be no use, because you'll try to split it. The central portion of the fibers are still going to be there and they will not break. But on the contrary, if you do into the center and you split this, the periphery will automatically break. So you have to target the center, which is more important, and targeting the center can be on any form of nucleotomy, whether you want to do a trench, whether you want to do splitting, or whether you want to do a chopping. When you are doing a splitting, you need to make a groove. You have to go into the same groove again and again, so that you are at about 90% depth. Some reflex should come and you should see the tip of the needle as to how deep it is going, and then you have two forces by which you can split the nucleus. Now, one important thing is that often an insufficient trench has been created. So when you are looking at an insufficient trench and you are doing a crack, this is how the vector forces work, and you know this is not going to break the backbone. So until, of course, you are deep enough, once you are deep enough and then you have your two instruments that is there, then the crack will automatically come and it will break this. So if you are being superficial and attempting to crack, you are going towards failure. You can do that for a softer cataract, but for a harder cataract, this is not going to work at all. There are several ways to skin a cat, as they say. So you could choose any of these ways for doing a hard cataract. Suffice to say, it is your decision. But for me, I am a primary chopper. I just go in, hold it with a good needle. The bent of the needle should not be more than 0 or 15 degrees. It should be a flat needle, because that gives you more occlusion. The vacuum builds up and you get a good vacuum seal. If you have a 45, nobody actually uses a 45, but when we started doing phaco, we were looking for 45-degree tips. So this is what we do, is a primary chop. Other modifications could be you make a crater and then chop, you can sculpt and chop, or you can do drill and chop. So these are certain things that you do. This is just to show you, this was among the first machines that we had, where we could work at 400, 500 vacuums with a 19 gauge needle. And this was the sovereign that we had. So you can look at the density of the nucleus. Important thing for you to note is that I am going into the same trench again and again. It is the same trench, and you can see I have held near the mid, and I am trying to separate with the lateral movement. So just watch this lateral movement. You can see this is again attempting to break the backbone. See, this is now still attached, but we have cleaved it right to the middle. So what do? You go back on the other side and you again try to separate. In this particular case, you can see that again, this is the most important thing, that you had to separate and do the cleavage. And once you have the cleavage, then you can actually go ahead and remove each segment. Now you can see that each segment has been removed. This is again the hemisection that is left. Again, look at the depth at which I am going. It is not a superficial crack, it's deep. You can see once it is deep, then only you can have the crack coming, and be sure that you are disenclavating or breaking this backbone or this spine. You can see I separated it to separately, then only the whole thing will come, otherwise it will not come. This is a further harder cataract. This is a black cataract. As you can see in this, we have pre-chopped the nucleus with a femto. Today 80% of my procedures are being done with femto. In femto, we would want a slightly larger capsulorhexis, about 5.5 instead of a 5 millimeter, because we want the hard pieces to come out. Do a gentle hydrodissection. This is, you feel that nothing has been done except for the capsulotomy. But mind you, the amount of energy that you will lose will be much less. So this is going in. You can watch here. Just see this. Getting a good hold and a good grip. And could you see those air bubbles coming? So what this air bubbles are actually signifying is that it has gone and cleaved. When you are doing a femto procedure, a white cataract will not allow the femto to cleave in the posterior part. But as long as there is visibility to see the posterior part, it will go ahead and do the cracking. So you can see again, this is a piece that we have been able to take out. This is the key thing that I am telling you. You have to take out the pieces, break the leathery connections which are there. An incomplete section of the nuclear fragments following chopping is calling for disaster. So take your time, whether you want 2 instruments, whether you want to put viscoelastic, deepen the chamber, go separately, but see that the midline is broken. That is what I am emphasizing again and again. Next thing is that you don't have a support of an epinuclear cushion that you have. This is a white and a hard cataract. You can also take, if you have the money, you can have an OCT guided this thing. You can see here the fluidic patterns which are here on the OCT in this particular case. See this is a liquefied cataract, and you can actually plan and look at the posterior capsule, because often you can see there could be a problem in the posterior capsule in hard cataracts. So intraoperative problems can be many. The most important thing for you is an early detection of a PCR. I'm not going to talk about how you detect an early PCR, but the moment there is a PCR, stop, put viscoelastic, stop, then only withdraw, take a deep breath, and then understand what is the stage at which the PCR has happened and what are you going to do. And this is viscot or OVD, which is dispersive, will going to help you. A vitrectomy through the posterior part is going to help you. So I'm not taking the PCR part. I've just told you what all are important for you to look at when you are doing a hard cataract. Now finally, post-operative considerations. There is a prolonged surgical time that you have. What does this lead to? Prolonged surgical time will give you more inflammation post-operatively, whether it's a uveitic inflammation or a corneal inflammation. I always prefer the use of cycloplegics in hard cataracts. I would normally do these hard cataracts under a block. Otherwise, most of my cases are under topical anesthesia, and I would give a subconjunctival atropine at that particular time. The good old times we used to give subconjunctival, because it is well established that cyclitis, inflammation, there are endogenously produced down regulators belonging to the prostaglandin families, which are produced by the ciliary body, which causes corneal edema, which causes down regulation of the endothelial cells. So you have to stop this down regulation if you want a faster recovery of your corneal endothelium. The increased inflammation is also taken care of by atropine. You have to give intensive topical steroids, and for preventing CME, you need to give NSAIDs. Pressures can go high because you have used a lot of dispersive, viscoelastic, etc. So that's what you need to do. So these are, friends, the kind of tips that I would wish to say for a hard cataract. But patience is the biggest your companion. That if you have patience, any hard nut can be cracked by phacoemulsification. These kind of black cataract, my people were saying, the one that I showed with femto, my people were saying, go ahead and do an SICS. I don't know how to do an SICS at all. So my ego came between. I said, no, I'll just do a phaco. So you can see that if you are able to have patience and you are able to handle the hardest cataract. Thank you very much for your kind attention.
Thank you so much, sir. That was a lucid presentation, an excellent overview of the tips and nuances in hard cataracts.